So I want to talk about three things today, really. First is what have we done on What Works. Secondly, what have we given you, so what have you got? And thirdly, how should you use it? So those are the three things I want to talk about today briefly. We explained in the work that we did on the Science Within, which we shared with you previously, that the time from conception to a child's 4th birthday is an important window of opportunity. It's a time of risk, but it's also a time of opportunity. And it's important, therefore, that whatever work goes in to families and children during that period has a strong basis in evidence. It's important that practitioners know that what they're doing works, is likely to be effective. Parents and families are going to want to know that what they're getting is effective. And of course the funder is going to want to know that what you're putting in place is likely to work. So what we've done in the What Works information is set out information about the effectiveness of different interventions. And I should say here, we're focusing on a particular type of evaluation here. So this is not. So we're interested here in identifying interventions that have a positive impact on child outcomes, on nutrition, on children's on health, on social and emotional development, on language development as well. There are other types of evaluation, of course. So there's process evaluation to find out how well a particular intervention is being implemented. You could assess the cost of different interventions. You could try and find out whether the people who are using the interventions actually like them. But what we're interested in here is impact, in other words, the what works. What do we mean by work? We mean interventions that have been tested and found to be effective on one of two things, or it could be both. One of the better start outcomes, so I've mentioned them already: language, nutrition, social and emotional development, or some of the factors that contribute towards those outcomes. So, for example, the kind of things we talked about in the Science Within: parenting, the environment, maternal mental health, and so on. Okay, so an impact evaluation asks whether an intervention is effective on those outcomes, and it's particularly the key issue there is what's the distance travelled? Did the children or the families do better over time? And critically, was the intervention responsible for that? So you definitely want to have evidence here of what the children or family situation was before the intervention, and you also want to have some information about what it was like after the intervention. But that's not enough. There could be a whole bunch of reasons why there was improvement or deterioration over that period. It could just be that the family situation changed, and that's why things got better. And so because of that, we need to have a comparison group. A comparison group would be a group of children or families who are similar in as many respects as possible to the children or families who get the intervention, and the main difference is they don't get the intervention, and that's how we know that the intervention in question is effective. And there are two types of evaluation to be aware of here. The first is called experimental evaluation. This compares the progress of the intervention group, the kids or families who get the intervention, with that of the control group, in other words, those who don't get it. And there are two types of experimental evaluation. The first is when you randomly allocate children or families to the intervention in question. So let's say you want to evaluate an intervention to prevent or reduce obesity amongst very young children. You find the group of children or families you want to work with, and then you randomly allocate some to your intervention that you want to test, and some to a control group who don't get the intervention. And the random allocation is a bit like flipping a coin. It's there are statistical methods for doing it, but that's essentially what it is. And then you compare the progress of those two groups over time. And because the groups are very similar at the beginning, and therefore the only real difference between them is that one group gets the intervention, and the other one doesn't. If at the end of the intervention the ones who have been receiving it are doing better than the control group, you can fairly say that the intervention was responsible. So you can attribute the benefit to the intervention. You can also have a non-randomly allocated comparison group, and this creates what's called a quasi-experimental design, or a QED. And all this is instead of saying we've got our families and we're going to randomly allocate some to this obesity prevention program, some to a control group. You say we're going to put our obesity prevention program in place in this local authority, and we're going to find some similar kids in the neighbouring local authority, and we're going to compare them. So there's no random allocation, but it's generally considered an inferior method to random allocation. Increasingly, the whatworks literature is rooted in systematic reviews of dozens of randomised trials and quasi-experimental design studies. So, for example, a report might say, well, we want to find out what works to improve the way in which parents interact with very young children, or we want to find out what works to prevent or reduce maternal depression. And it will look for a whole load of studies that have been conducted on that particular issue, focusing usually on randomised trials and quasi-experimental designs. And it will try and take a balanced view of what that literature says. And we drew very heavily on systematic reviews in the work that we did, and I'll say a bit about that in a minute. A similar but slightly different approach is called meta-analysis, and this is more of a statistical method for grouping together or pooling the results of lots of different studies. So let's say you've got lots of studies of obesity prevention interventions, then you would put them all into a statistical package, and you'd kind of add them up, and you get a sense of what the weighted average is across all of those studies, and that would tell you whether overall that those type of interventions are beneficial for children or not. So the work we've done, and the reason I've gone telling you all this, and forgive me if I'm sure for many of you this is stuff you know already, is because in the work we've done for whatworks, and I should say I've done this closely with Jane Barlow at Warwick University, who many, if not most of you, would have met. We've been focusing mainly on interventions that have been evaluated by RCT or QED, because the brief was to identify the best available evidence. And so that was where we went in at. We did draw extensively on systematic reviews like the ones I've just described, and the advantage of that was that, as well as helping us to find discrete interventions that you might want to implement, it also told us about types or classes of intervention. So, for example, instead of saying, well, as well as saying, here's an intervention called Curiosity Corner, which is really good for improving children's language when they're about 3 to 4, it said, well, here, these type of early education programs are effective. So it tells you about discrete interventions, but also about classes of interventions. And we think that's helpful, particularly if you're thinking about innovating. You might want to take that on board. Okay. When interpreting the data, the whatworks stuff that we've given you, it's important to be very clear about what the intervention is that we're talking about. And you'll need to do some legwork here. We've kind of given you a kind of a way into the literature, I think, but you'll need to do some legwork on this. We think a useful distinction can be made between these 6 things: policies, practices, programs, processes, quality improvement methods, and population-wide interventions. And you'll see in what we've given you, we've attempted to separate things out in those terms. So a lot of what we have found falls in the kind of program category. So these are discrete, packaged sets of practices, often captured in a manual or some guidance that tells the practitioner what to do, in what order, when, gives them a whole load of materials and so on. But not everything is like that. Some of the things we've identified are practices. So, for example, motivational interviewing for helping people to reduce alcohol misuse. That's not a particular program. It's a practice. And we've also said we think there are some useful processes that you should be considering, particularly around screening and making sure that the right intervention gets to the right family, right children. We can also categorise interventions according whether they are for everyone or whether they're targeted at a select group of people. In whatworks, we've categorised them as follows, using six levels, which sound a bit obscure, but I'll try and explain them briefly. So the 6 levels are promotion, and this kind of, I should say, this is a spectrum for everyone to very, very targeted. So promotion, universal prevention, selective prevention, indicated prevention, treatment, and maintenance. Those are the 6 levels. And in the material we sent you, we give some fairly long academic type definitions. But in short, promotion is trying to promote good things for all children, all families. Prevention is working with all families or children, trying to prevent bad things from happening. Selective is working with families or children where there's an elevated level of risk, and you're trying to prevent the problem from developing. Indicated is when there are problems, but it's not diagnosed, it's hasn't reached that kind of clinical level. Treatment is where where something has been diagnosed, maybe conduct disorder, for example. And then maintenance is where you're trying to trying to maintain the benefits from the treatment, trying to stop things from deteriorating. And I think the stuff we've identified does go across the board. I don't think we found very much that you would consider to be maintenance, but otherwise I think it goes across all of those levels. Okay, this bit's really important. One of the things we're very keen for you to do, and it was central to the way we approached this, was that you want to connect the whatworks stuff to the science within. So I don't know if you remember this diagram. This is kind of like halfway through the science within, and this is the point where we say, okay, taking into account what the science says, this is what a vision for a good childhood looks like. So here, I know you can't see it at the back, but this is what's really good in pregnancy. So for mother's physical health, they've got a healthy diet, no smoking, no alcohol, drug misuse, good exercise, etc. When they get into infancy, for social and emotional development, positive parent-child interaction. For nutrition when they're in toddlerhood, that they're eating healthy foods, healthy eating patterns and so on. That's kind of a vision for a good childhood. And the whatworks is very closely related to that. And certainly in the way we've tried to present it to you in the tables and the overarching narrative, we use these broad headings. How to improve mothers' maternal health, how to improve children's social and emotional development, and so on. As I say, the whatworks information that we've provided you is really saying, okay, you've got the science within, and now here is the best available evidence on the type of activities that are going to be useful for achieving those outcomes. I'm going to summarise what we've given you as follows. I think there are 5 parts really to what we've given you. Firstly, we've identified interventions or types of interventions that have been shown through comparison group studies to impact on the outcomes or factors or relevant factors like neighbourhood violence, parenting, maternal mental health, and so on. Secondly, there's a big table which I think is a bit horrible. I'd be interested in your views on it, but where we kind of say, for all these different interventions, we say, well, this is the nature of the evidence, and we summarise it very briefly. So we say there's an RCT on it or a QED on it, and this is what it shows. So it shows that that this reduces maternal depression, for example, or that this increases rates of breastfeeding. Thirdly, we categorise the interventions according to the 6 levels that I talked about earlier. We've kind of simplified it a little bit in the sense that we've kind of bunched those 6 levels into 3, which may or may not be helpful. Again, I'd be interested in your views. Fourthly, in the narrative document that you've received, there is we try and give you a sense of how some of these things might fit together chronologically, and we're not deterministic in this. We're not saying you must do this, when in parenting, you must do this when the kid's 1 and when the kid's 2 and so on. But we use the concept of care pathways just to give a sense of there are different staging posts in the period from conception to a child's 4th birthday, and at different points you can introduce different types of intervention depending on the family's needs. And then the last thing we've done is that in the narrative, because everyone recognises that it's all very well having a good intervention, but if you don't implement it well, it's not going to be very much use. So we give a very potted summary saying, here are the kind of things you need to be thinking about very hard when it comes to implementing these interventions. So you need to think really hard about how we're going to promote fidelity, how are we going to make sure that the right children and families are connected into the interventions. In particular, how are we going to reach the so-called hard to reach, or how are we going to make our services more accessible. Okay, so that's what we've given you. I'm going to say a brief word now about how we would encourage you to use this information. And there are several steps to this. The first thing, this is critical, I know Tim's talked to you about this morning, is to look at what the child wellbeing data tells you. What does it tell you about outcomes that you should focus on, that you should prioritise? What does it tell you about risk factors or protective factors? How do they relate to the normal population? And that will give you a sense of where you should focus your efforts. So you might, for example, say, well, we're going to really focus on social and emotional development of 2 to 3 year olds, and we're really going to focus on maternal depression during pregnancy. Second, I think it's then I would encourage you to go, rather than go straight to what works, go back to the science within. And in the science within, towards the end of it, we try to say, well, here are the kind of activities you might want to do. Because the reason I say this is, why I say don't go straight to what works is, if you go straight to what works, the danger is you'll just come up with a list of interventions, and you won't be thinking innovatively about it. If you go to the science within and think, well, these are the kind of things we might want to do, it allows you a bit of freedom to innovate. And one of the key messages we're keen to get across, and we think we've been consistent in this, is that your portfolio can be a mixture of evidence-based interventions and so-called science-based interventions. And the science-based ones are ones that don't have the level of evidence I talked about earlier, but they are based on the science within. They're based on an understanding of the kind of things that matter in the development of young children. Then I think you can go to the whatworks stuff, whatworks documents, and it should be relatively easy to go through that information and begin to identify interventions, or the types of interventions that meet your criteria. So that, in other words, they focus on the outcomes or risk factors that you've decided you want to focus on, and they do it at the right level. So they're universal or targeted, and so on. And this is going to give you a short list of interventions, or the types of interventions that you might consider implementing. I think you've then got to do a bit more work on it, and I think the first thing is you've got to find out a bit more about what those interventions are. So we don't give you a lot of information about that. We're planning to give you a bit more than we've given you, and that will hopefully come in the next month or so. But you can find out quite a lot about these interventions often through the internet. A lot of these interventions have fairly good websites. So one of the things you want to find out in some detail are what outcomes are they targeting, what's the target group, what are the actual intervention components, and critically, what's the theory of change or logic model underpinning the intervention. We give this a lot of stress in our report, because we think that if you and the people who are going to be implementing these interventions understand why they do what they do, it's more likely that they'll be implemented well. We've got good evidence, just good evidence so far. The second thing you want to do is look a little bit more critically at how these different interventions have been evaluated. So we've gone fairly high level and said we found here are some things that have been evaluated by comparison group studies, randomised trials, or QEDs. What we haven't done, and it's largely a product of time, is go into those studies and begin to pull them apart and appraise them critically. And you want us to do some of that. You'll probably need some expert help, but there are some shortcuts as well. So, for example, there are various online databases that have done some of the legwork for you, and they say these are our standards, and if the intervention gets onto the database, you know it's met the standards, and if it doesn't, you know it hasn't. So that's a shortcut that I encourage you to look at. And this is the last thing I'm going to say, really, and it's that we have to be cautious here, because a lot of the evidence comes from studies conducted in other countries. We don't have a very good record here in the UK of doing randomised trials or QED studies. So you would want to think about, we talked a bit about this yesterday, but you want to think about whether some of these interventions are suitable for the UK, so you need to give that a bit of thought. I think what we're fairly confident of is that what we've given you, which we will continue to update until at least the end of March, is a pretty good insight into the best available evidence. We're not saying it's completely comprehensive. We would have missed things, and if you come across things that we've missed, then tell us about them, because we want to include them. But we hope this is a kind of a useful way into a lot of literature.